Thanks so much for having me. I am a gynecologic oncologist and bioethicist by training, and so it's always a privilege to visit other communities that have focuses on different disease sites and kind of see how some of the problems that we encounter across different cancer types are really very similar, and how cross-training to a certain extent can really benefit everybody. So one of the things that I would like to address today, again, don't have a whole lot of time, so like Dr. Mehta, I'll probably try to create more questions than answer, is to focus in on local cancer care delivery and addressing inequities that are rampant throughout the cancer care delivery infrastructure in the United States. We'll talk a little bit about how those challenges can become not only practically but very ethically challenging. We'll hopefully bend your brains in a couple of challenging ways, and then I will suggest some ways of getting through those ethical challenges in the service of promoting equitable cancer care. From a disclosure standpoint, I'm a member of one advisory board outside the scope of this presentation, and just want to stipulate that none of the views expressed here necessarily represent any official policies or positions of the American College of Obstetricians and Gynecologists. So the focus of the time that I want to spend today is on local cancer care delivery and promotion of equitable cancer care at the health system or at the clinical practice level. And so, you know, having followed an outstanding presentation highlighting a particular population of interest in the lung cancer world, what I want to sort of shift to just for a moment is how do we take big data, translate the questions and problems that are sort of brought to light by the big data, and make programs at the local level that serve to ameliorate the problems that have been identified. So, you know, I pulled what probably is a familiar type of figure for all of you in this room, showing the clustering of smoking and cancer morbidity, to make one specific point, right? It is not immediately apparent exactly what the deficit is, if there is one, in access to cancer care or in cancer care delivery based on this diagram, right? It's hugely important. I am not in any way downplaying the need for these kinds of studies, but if you put yourself at any area on that map, right, you're still gonna have some of the same questions about how to identify populations in need, how to find what I'm gonna call an equity signal, right? Differences amongst different groups of interests in outcomes of interest. And then you're gonna need to figure out, well, how do we address that clinical equity, that problem in clinical equity? So what do we do with this? This slide is mostly material that I think runs in the background of everyone's brain who's involved in cancer care, right? Like each practice sets up its own ecosystem for the delivery of lung cancer care, right? Where do you, in the environment that's local to where you are, get, right? Where do patients go for imaging, for the clinic visits? Where do they get their surgery if needed, their systemic therapy, radiation therapy? And then recognizing that oncologic care is not the only care that patients have a need for on the cancer care continuum, right? Like these are patients who have other needs because they're people in addition to being cared for their lung cancer, and even in a preventative or a screening setting. So where are the gaps in care, right? These are very specific questions that each health system has for itself. Who is experiencing the gaps? Is there this equity signal that we're seeing differences in the outcomes that we want to see based on groups that we think are frankly morally relevant? Why is there a gap? And how do we address the challenges in local cancer care delivery? None of these questions are new to anybody, but I want to bring them sort of to the fore. All right, so again, as with any good programmatic question or any research question, there's utility in being as specific as possible, right? Exactly which patients are we talking about? Exactly what intervention are we concerned about utilization for, right? Is it a screening? Is it a treatment? Is it a survivorship intervention? The more specific we can be, obviously the better, right? Is there a geographic component to this? When in the cancer care journey are we seeing gaps that we think are morally relevant? And then of course, why are the gaps in existence? And as we all know, that it requires a sort of rich engagement with both the healthcare system as well as the community that is effective. right? We want to be patient and community focused. We want to be creative with our access solutions if we think that it's easier for one group of people to get what we consider to be high quality cancer care than another group. That's something that generally requires more investigation and focus. Okay, so we all know this. We know this can get very challenging, and so the practicalities also get very ethically complex, and I'll spend the rest of the talk talking about those ethical tensions and how to navigate them. All right, question number one. So we know there's a problem. How should we define the solution, right? So we say, well, we've noticed that 20% of the eligible population for a screening intervention is utilizing the screening intervention. And we sort of instinctually say, well, that's a problem, right? Because we know that screening leads to diagnosis, which leads to early treatment, which leads to lives saved. One of the things that we've spent too little time on, unfortunately, is saying, well, one of the problems, because there's a utilization difference, is that there's a problem in access to care, right? But we don't actually know what access to care means, and it's never been satisfactorily defined in any literature, either in the philosophical world or in the medical world, let alone the cancer care delivery world. So a lot of times we go straight from that utilization signal to an access signal. We say, among this group, utilization of this intervention is way lower than we want it to be. And we say, well, it's multifactorial, right? And some of those factors have to do with access. Well, we haven't really pinned down what access is. And so one of the things we need to think about, and again, I won't answer this question, but I'll raise it, is whether we mean utilization, right? We know that there's good access because there's good utilization. Is that what we want to say? Or do we want to say something broader, saying the ability to utilize is what we mean by access? And the practical difference there is to preserve, for example, room for patients after an informed discussion with their clinical team to say, although I am a candidate for that measure of whatever sort, I decline to use it for reasons that are consistent with my own preferences and values and sort of, support structure, right? We need to preserve that. And I think, the practical importance of that definitional change is that our target access goal is not going to be 100%, right? I think that's important. The ideal target for a lot of these interventions, all of the things that we know to be consistent with high quality cancer care, we probably shouldn't say up front that we want 100% utilization, because we need to preserve that ability for, an informed shared decision-making process between clinician and patient to say, perhaps even though this is available, this is accessible to me, I decline to use it for any of a number of good reasons. So if we're not targeting 100%, what's our target? Well, I can't answer that for you, right? Some of it needs to be even taking into account the informed refusals, what do we think is a reasonable ideal goal? And then there are the practicalities of saying, being consistent with what we know about nudges and behavioral psychology, that maybe what we want to say is our target is something that's incrementally achievable and not too scary for the people that are trying to implement the practice change, right? And this is important to grapple with, and it's important to be explicit about why you're doing it, right? If you're saying that, look, we think that all things considered, we want 80% uptake of a screening intervention, we're at 40, we can't say 80 because we won't get buy-in, so let's say our target is 50, right? And again, the numbers are all made up, but I think you can all sort of reflect on your own experience and say, we need to be very clear about what ideal is in the long run, and then what's incrementally achievable. And then this is what we're going to set as our policy goal, all within sort of the underneath the umbrella of improving access to care. And it just gets challenging. So another important question that I think gets less attention than it deserves is, what is our priority for improving outcomes? Again, we can't pretend that we work in an ideal space, right? There is rampant inequity in cancer care delivery in all disease sites, lung cancer included. And we are going to see situations that are like this schematic that I've put at the bottom of the slide, and I'll walk you through it real quick. So the idea here is that there is some intervention of interest. You can call it high quality surgery, just for the sake of argument, okay? And that group A, in all cases, from left to right, Group A utilizes high quality surgery more often than group B, we'll say all things considered, controlling for the things that we think are important. The red line represents what we think is an acceptable minimum threshold, right? So again, what we were just talking about, like if we think that 50% is appropriate, so on the far left, both groups are different, but they're all above that 50% threshold, right? In the middle, those two groups straddle the red line, and over on the right side of the screen, there's a difference between the groups, but they're both falling short of what we want to see overall, yeah? So the question becomes, where does and to be clear, like I think that this is the example that is in play with pretty much everything that we do, right? I don't think this is boutique here, right? So you're gonna have across whatever, sociodemographics, economics, geographic, whatever, group-wise comparisons you guys think are important for your intervention, you're gonna have something like this. You're gonna say we're falling short of where we wanna be, and there are between group differences. What are we gonna do to utilize our scarce resources, grant dollars, person power, person hour power, right? Do we look to equalize the between group differences first, because that concerns us more? Do we look to first raise everybody above that red line because we've put a lot of thought into what that red line should be? And to be clear, there are going to be situations where what you're doing is bringing group A down to group B because maybe in the scheme of things, you're towards that right end of the incremental benefit curve and you might have something that's overutilization, right? And the resources that you save by decreasing the overutilization can be used to bring other groups above that red line, right? Again, these are all possible things that could make sense given the peculiarities of the clinical intervention and the care environment that you situate yourself in. But you have to, in my opinion anyway, you have to contend with what you're actually doing as you seek to either equalize between group differences, raise all ships, so to speak, even understanding that your effect is not gonna be A is equal to B and both A and B are at your target, all right? Another example here, looking at geographic inequities in care, right? The chloropleth GIS related geographic maps of services and accessibility are all over the place. I think they're hugely interesting, they're hugely important. How do we bridge geographic gaps? There are only three ways, right guys? You either send the clinicians out or the cancer care team out to where the patients are. That's traditional in-person outreach, right? You centralize care, you bring the patients into where the clinical team is, or you do something virtually. I mean, if there's any other logical sort of option that I've neglected, please do let me know, but I think these are the broad categories, right? So now we have to think about when we bridge distance, which is ideal, what's the best way to deliver care, and then which is adequate, which serves the purpose to give at least the basic standard of care for patients with cancer. And here's a very fundamentally challenging question that we do not want to ask, right? When, if ever, is it ethical to implement non-ideal but acceptable care in the service of improving access? I'm gonna let that marinate for just a second. Okay, so I wanted to give like a quick example from GYN oncology because I think it serves. So, one cytoreductive surgery is still the standard of care for patients with metastatic ovarian cancer, and GYN oncologists as a whole are sensitive, as is everyone, to the correlation between improved outcomes of highly complex procedures in centers that are accustomed to doing those highly complex procedures more often, right? So the volume outcomes relationship. And so there has been / had been a call to centralize all of the most complex surgery for ovarian cancer in the high volume centers and de-implementing, that's the more important part, right? De-implementing those services in lower volume centers because quite reasonably we said to ourselves, we want to make sure that if you're doing a thing, right? If we are providing a complex service to our patients who need it, then we want them to get the best outcomes possible, right? Now the problem, as you're all thinking about, is like, all right, well, what about the patients who aren't anywhere near one of those referral centers? So yes, you are correct. We have decreased access to that complex intervention in the service of maximizing outcomes. And there are people who still argue that that's okay, I'm not one of them. So one of the things to think about, and this is an argument that I and others have made, is that it is acceptable to implement less than best, but still good interventions in the service of access to people who otherwise would have insurmountable barriers to getting to where you want them to go, if, and I would say if only if, the following safeguards are in place. So number one is that the standard of care has to be acceptable, and that's going to depend entirely on the clinical disease experts within the field, right? So it can't be a baldly unacceptable standard of care that's being implemented. And the second is that it has to be community specific, right? So if it's a geographic barrier, then you have to be making things more geographically accessible to the community that you're interested in. The second is that you can't just implement something that's not quite as good as you want it to be and leave it there, right? This has to be part of a sustained programmatic improvement in the access to care. And then finally, the site of care needs to be part of the shared decision-making process for each and every patient, right? So you are not mandatorily allocating patients who are far from the referral center to care away from the referral center. You know, I can talk for a long time about travel preferences for complex cancer care, but it is not easy and it is not simple. And some patients are willing to travel and some patients would rather not travel and not get acceptable cancer care. So that has to be part of the discussion, preferably in the setting of rural patients with rural cancer care navigators, to really dig into what makes sense locally versus centrally. Okay, second and last example is a very well-known one to this crowd, and that's financial toxicity of cancer treatment, right? The figures, again, just for the refresher, 2 to 34% of patients with cancer get medical debt, about 2% medical bankruptcy rate, which is outrageous. I don't know that anyone here would disagree with that. And that we know that the best approach here is multimodal, right? So screening for financial need, for the potential for financial toxicity, considering the cost effectiveness of all recommended interventions, the maximal assistance possible from financial navigation, making sure that people are hooked up with the resources that might benefit them and decrease the risk of a downstream catastrophic financial effect. And then, of course, to the extent that it's possible, and we've all banged our heads up against this one, actual transparency for out-of-pocket cost, preferably before, right, the intervention is undertaken, so that there is some concept both of whether that intervention is desirable and also to implement prophylactically, right, the resources to help support patients in their financial needs. Okay, but then what? Right, so all that, all of that is best practices. It's not easy, it's incredibly hard, right, from the systems level and from a programmatic standpoint within a healthcare system. But then what do we do once we have all that information? We've got to engage with the realities of cost-benefit trade-offs, right? And this is so hard, right? We are not in an ideal care delivery environment. And once we get all of the cost data up front and patients are able to consider, what their financial capabilities are, we've got to have the conversation about what's next, right? So we know, because this is how all of our clinical trials are designed, what the incremental clinical benefits are of every intervention, right? You look at the 2 survival curves. You look side by side at the adverse effect data. Like, our knowledge generation apparatus is designed to give accurate information, usually to clinicians, but hopefully often to patients as well, as to what these benefits are. And you can decide about what the cost is, but we've got to get comfortable having the conversation in the context of the financial toxicity, insofar as we can actually counsel patients about what that cost is going to be. And I say this to be clear, like, I recognize, you recognize that financial toxicity is unfair, right? We need to work to make it better, but at the same time, we have to also get used to working into this non-ideal space as we exert a tremendous amount of effort to get to the ideal one. All right, some takeaway points, right? We are all committed, I think it's safe to say, to working towards universal access to high quality cancer care. And we also recognize that high quality cancer care is nowhere near universally accessible at the moment, right? Not a controversial point. But incremental improvement under non-ideal circumstances requires us to grapple with challenging ethical tensions as we seek to improve equity in cancer care. The examples I've given you, being super precise about thresholds, right? Even understanding everything's arbitrary, but you've got to put your money down somewhere. What do we do about improving access, even under non-ideal circumstances geographically? How do we grapple with cost-benefit trade-offs in clinical care as we seek to decrease financial toxicity, but also seek to improve the transparency of what that cost is going to be? And as an evidence-based ethicist, I think that all of these questions are solvable, but they require exertion of the same amount of effort to the ethical side of things that we exert on the clinical efficacy side. Thanks so much. It's been a pleasure.